My name is Chan Cheah. I'm a consultant haematologist at Sir Charles Gairdner Hospital and Hollywood Private Hospitals in Perth in Western Australia. Diffuse large B-cell lymphoma is the most common subtype of lymphoma overall. It makes up somewhere between 35 and 40% of all lymphoma diagnoses. Patients with diffuse large cell lymphoma have a median age of diagnosis of about 60, which means half are diagnosed above that and half are diagnosed below that. Of the 7,000 patients diagnosed with lymphoma each year in Australia, so probably we're looking at 2,500 to 3,000 of those patients will have diffuse large B-cell lymphoma. So we know a reasonable amount about how to treat this condition. There are a few different subtypes of diffuse large B-cell lymphoma. And the way that we subtype it is really based on a couple of things. We look at the what we call the cell of origin, and that provides a useful way to separate diffuse large B-cell lymphoma into different cases. The two main types are germinal center diffuse large B-cell lymphoma and activated B-cell diffuse large B-cell lymphoma. And the distinction between those two is generally made in a routine diagnostic laboratory with the protein expression. So the biopsy gets taken based on the expression of a number of proteins. We can classify patients into either one or the other category with a reasonable degree of accuracy. Diffuse large B-cell lymphoma is a aggressive or fast-growing lymphoma, which means that the lymph nodes usually grow in size reasonably rapidly over days to weeks rather than months to years, as in an indolent or a slow-growing lymphoma. And the common way that patients are diagnosed is, like many forms of lymphoma, an increasing lymph node, which is felt by the patient. If patients have quite a lot of lymphoma, they also may have symptoms such as drenching sweats at night time, unexplained weight loss, or high temperatures. In terms of why patients get diffuse large B-cell lymphoma, most often we don't actually know. For any individual patient sitting in front of me, I usually don't know the answer to that question, and it's probably a combination of environmental factors and genetic inheritance. We do know that there are risk factors for developing diffuse large B-cell lymphoma. Probably the strongest one is a history of suppression of the immune system, and so that can be either something that you're born with, for instance, if you've inherited a condition where your immune system doesn't work properly, or it can be due to something else which has happened, such as, for instance, HIV. And having HIV dramatically increases your risk of developing lymphoma. Also, patients with autoimmune disorders like rheumatoid arthritis, who often need further immune suppressing medications, also have an increased risk of developing lymphomas. There also appears to be a subset of people who have infections, chronic infections, which increase the risk of lymphoma. Probably the most notable example here is Epstein-Barr virus, which causes glandular fever. We know that in a proportion of patients that can cause lymphoma. And in patients who've had previous chemotherapy or radiotherapy, we know that is a risk factor for developing lymphoma as well. Finally, in terms of family history, we know that most patients with diffuse large B-cell lymphoma don't have a relative with lymphoma, but if you do have a first-degree relative with lymphoma, you probably have around a 3 times increased risk from baseline compared with someone who doesn't. What is the frontline treatment for diffuse large B-cell lymphoma? The answer to that is it depends. It depends on the stage and the prognostic factors of the patient's lymphoma. So we talked about staging the staging probably is going to be a separate video that Michael's going to do?
Yeah, he's going to do that one, yeah.
No problem. Okay, so in terms of the treatment, it can be broadly divided into limited stage and advanced stage. We consider stage 1 or stage 2 diffuse large B-cell lymphoma to be limited and stage 3 or stage 4 to be advanced. In the case of patients with limited stage diffuse large B-cell lymphoma, the treatment is R-CHOP, which is 5 chemotherapy drugs, rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisolone. So the rituximab is given as an infusion, as are 3 of the other 4 drugs, and the prednisolone is given as tablets. The treatment's given once every 21 days, and it's an outpatient treatment, which means you come to the hospital for the day and then you go home. In limited stage disease, we're often able to get away with a shorter number of cycles of chemotherapy, for instance 4 instead of 6, without compromising outcome. And there's been a couple of randomized trials which have shown that that is a feasible and safe approach, which reduces side effects but maintains the effectiveness of treatment. Similarly, in advanced stage disease, for the majority of patients, the treatment is also R-CHOP, but it is usually 6 cycles of treatment. The one exception to that would be a group of patients who have a higher risk disease, and that is known as double-hit lymphoma. Double-hit lymphoma is defined by the presence of specific gene rearrangements in 2 genes, which we do testing on the lymph node biopsy. The names of these genes are MYC and BCL2, and there's a 3rd gene called BCL6. If you have mutations in MYC and one of either BCL2 or BCL6, that means that you have a more aggressive subtype of diffuse large B-cell lymphoma called double-hit lymphoma. And there are some data suggesting that the use of a slightly more intensive chemotherapy program called dose-adjusted EPOCH with rituximab may be beneficial for that subset of patients. When is CNS prophylaxis required for patients with diffuse large B-cell lymphoma? This is actually a special sort of research area of interest to me. It's we didn't talk earlier about prognostic factors, but there are 5 clinical features which are used as prognostic factors in patients with diffuse large B-cell lymphoma, and they make up a scoring system called the International Prognostic Index, or IPI. So these are basically, if you're aged over 60, if you have an elevated blood test called lactate dehydrogenase, if you have stage 3 or stage 4 lymphoma, if you have more than one what we call extranodal site, which is an area of lymphoma which is not in a lymph node, such as the blood or the bone marrow or an organ like the liver. And finally, if you're not very well, so it's a measure that we call performance status. So the more of those points that you have, the higher your risk in terms of your lymphoma. And in large studies which have been performed in Germany and Canada, it's become apparent that those 5 factors, as well as a 6th factor, which is involvement of the kidney or adrenal gland, can be used to estimate your risk of lymphoma spreading to the brain. Overall, in most patients with diffuse large B-cell lymphoma, this is not going to happen. If you took 100 patients with diffuse large B-cell lymphoma at diagnosis, the likelihood of getting spread to the brain would probably only be about 2 or 3% overall. However, using that risk score which I mentioned, when applied to the risk of brain or spinal fluid development, we call this the Central Nervous System International Prognostic Index, or CNS IPI. We know that patients who score 4 or more on this scoring system have about a 10 to 12% risk of developing spread of their lymphoma to the brain. And I and many others use that as a threshold for doing specific treatments to try and reduce that risk, and that treatment is largely the use of a drug called methotrexate, which is able to penetrate into the brain and the spinal fluid in the way that standard chemotherapy such as R-CHOP is not. The question is, what's the prognosis of patients with diffuse large B-cell lymphoma? On the whole, around 2/3 of patients are cured of this disease. However, it is possible to provide a more accurate estimate of prognosis using the International Prognostic Index, which I mentioned earlier. So using this scoring system, we can divide patients into a very good, a intermediate, and a high risk group, where we're able to estimate their likelihood of being cured of their lymphoma. So in addition to that, we also are aware that there are specific features about people's lymphomas, such as the expression of proteins including MYC and BCL2, and the presence of genetic mutations such as MYC and BCL2 and BCL6, which provide further information about prognosis. So in other words, the answer to that question really depends on the individual patient, how many lymph nodes are involved, how well they are, and a few other things like what their biopsy shows. Using all of that information, we can usually put together a reasonably reliable estimate of what someone's prognosis is likely to be.